This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Neurology India titled Effect of Pharmacological Neuroprotection During Surgical Clipping of Anterior Circulation Intracranial Aneurysm on Neurological Outcome, a randomized controlled study.
This is a topic that hits home for anyone who spends time in the OR. When we are dealing with anterior circulation aneurysms, whether it's an ACOM, a PCOM, or an MCA bifurcation, the use of a temporary clip is often a necessity. It helps us soften the aneurysm sac, making it safer to dissect the neck or manage an intraoperative rupture. But as we all know, that temporary clip is a double-edged sword.
Exactly, Dr. Aris. The abstract highlights that while temporary clipping is frequent, it involves a significant risk of cerebral ischemia. That's the core problem this study addresses. How do we mitigate that ischemic risk effectively?
Right. And historically, there have been two main schools of thought, or perhaps two main tools in our belt. One is reactive, and the other is preemptive.
That's a great way to frame it. The study mentions that the usual approaches involve either detecting ischemia as it happens, using somatosensory evoked potentials, or SSEPs, of the relevant arterial territorial distribution, and then taking corrective measures, or the preemptive route.
And that preemptive route is what this specific randomized controlled study focused on, the use of pharmacological neuroprotection before we even apply that temporary clip to the parent vessel.
For the residents listening, let's talk about the mechanism mentioned here. The goal of this pharmacological intervention is to induce burst suppression on the EEG. Dr. Aris, could you explain why we aim for burst suppression in this context?
Certainly. When we use agents like propofol or thiopental to achieve burst suppression, we are essentially reducing the cerebral metabolic rate of oxygen consumption, or CMRO2. By quieting the brain's electrical activity, we hope to make the neural tissue more resilient to the decreased blood flow caused by that temporary clip. We are trying to widen the ischemic window.
This study specifically looked at the effect of this preemptive pharmacological neuroprotection on two things: postoperative neurological deficits and the overall neurological outcome. They focused specifically on anterior circulation intracranial aneurysm surgery.
It's an important distinction because the collateral circulation and the relevant arterial territorial distribution, as the paper phrases it, differ significantly from the posterior circulation. In the anterior circulation, we are often relying on the circle of Willis to compensate while that temporary clip is on.
And that's where SSEP monitoring usually comes in. If the SSEP signals drop, the surgeon knows the collateral flow isn't enough and ischemia is occurring. But this study is asking, instead of waiting for the SSEP to tell us there's a problem, does preemptively shielding the brain with medication improve the patient's final outcome?
It's a vital clinical question. If we can prove that preemptive pharmacological neuroprotection reduces postoperative deficits, it might change the standard of care for how we manage the clip time. Many surgeons worry about the systemic side effects of the drugs used for burst suppression, like hypotension, which can actually decrease cerebral perfusion pressure.
Precisely. It's a balance. The study is a randomized controlled trial, which is the gold standard for answering these kinds of questions. They're looking for high-level evidence to see if the corrective measures approach triggered by SSEP is enough, or if the preemptive pharmacological approach is superior.
I think for our listeners, especially the medical students, it's worth noting the terminology used here. When the authors talk about the parent vessel, they are referring to the main artery the aneurysm is sitting on. When we temporarily clip that, everything downstream is at risk.
And the territorial distribution refers to the specific area of the brain supplied by that parent vessel. If we're clipping the A1 segment of the ACA, we're looking at the SSEP changes in that specific distribution.
This study from Neurology India really forces us to look at our intraoperative protocols. Are we doing enough to protect the brain before we even pick up the temporary clip? Or are we relying too heavily on monitors to tell us when damage is already starting?
It's about being proactive versus reactive. The researchers studied the postoperative neurological outcome as their primary endpoint, which is what ultimately matters to the patient and the surgical team.
Well, this has been a great dive into a very pertinent study. For those of you in the lab or the clinic, keep an eye on how these pharmacological strategies evolve.
Absolutely. Thank you for joining us on the Neurosurgery Hub podcast. We'll be back next time with more deep dives into the latest literature.
See you then.